Hi, thank you for having me today. I'm excited to see so many people join us for this. I like to think it's a testament to my charm and public speaking skills. I think the reality is there's, a paucity of information for women out there on this. And it's a testament to how many people actually, deal with this condition. So before we start, as mentioned, I am a urogynecologist. I operate at Sibley Memorial Hospital, which is a hospital of Johns Hopkins, and my clinic is in Arlington, Virginia, in the Ballston area. So today we are going to focus on one of the conditions that about 50% of my patients see me for, which is vaginal prolapse. It's an incredibly common condition. So common that up to 15% of women in the United States at some point will have surgery for it. Before we review what prolapse is and the treatment options for it, let's go over what exactly a urogynecologist is. I find a lot of my patients say, I didn't even know this was a specialty. So it is someone who's done 4 years of residency training in obstetrics and gynecology, and then went on to do 3 additional years of specialized surgical training in the pelvic floor, conditions such as incontinence, prolapse, and the surgical treatment of these conditions. A female urologist, on the other hand, is someone who completed a urology residency and then it did an additional 2 or 3 years of training in female pelvic surgery, such as prolapse and incontinence. Female urologists will also treat like standard urology things such as kidney stones, bladder cancers, whereas urogynecologists are more specialized in female specific conditions. So we don't do stones, bladder cancer, that sort of thing. So sometimes female urologists don't feel as comfortable treating vaginal prolapse since they didn't complete a residency in gynecology. It just kind of depends on their training. So first let's start with just basic anatomy. So this is a picture of your pelvis. So this is as if I were to kind of cut a patient in half and look at them from the side. This is the female pelvis. And so you have your pubic bone, your bladder here, I'm not sure if you can see, can you see my cursor on this for the moderator? Can you see my cursor?
No, we can't.
Okay, well, so you can see the bladder there, the uterus, and then the rectum in the back. And then the muscles that it's showing, let's say pelvic floor muscles, are the muscles that you typically would squeeze when you do like a Kegel exercise. And so in between these structures, you have ligaments and muscle and tissue that keep things where they're supposed to be. So keep them in this orientation. And sometimes when these get disrupted or weakened, you can develop prolapse. Prolapse can occur at the top of the vagina, the front of the vagina, or the back of the vagina. And most people who have prolapse do have loss of support in all three of these areas. Sometimes one side is worse than the other, but typically it's not isolated to just one side. So as mentioned, the types of prolapse are, excuse me, the front of the vagina, which is called a cystocele, because the bladder sits on top of the front of the vagina, you see some loss of support of the bladder there. So some women may say when they feel like their bladder is full, they feel like the bulge is worse, right? Because the bladder is sitting on top of it. It's called a rectocele when it's the back side of the vagina, and that's because the rectum sits right behind the backside of the vagina. So often women will say they see or feel a bulge, or sometimes they feel like when they're trying to have a bowel movement, the stool is just stuck at the opening, like they can't quite get it out. And sometimes women even find they need to do something called splinting, where they actually put their finger in the vagina or at the opening of the vagina to kind of try to push to reduce that bulge and allow the stool to come out. So you can see again on the original picture here, it's just a straight trajectory when you normally have a bowel movement, but when you have that loss of support or pocket, it's more difficult to get out because it creates a little pocket there that the stool will often get trapped in. If the top of the vagina is coming down, that's called uterine prolapse. So if you don't have a uterus, it's called vaginal prolapse. So these pictures are just depicting the uterus coming down and the top of the vagina coming down if you might have had a hysterectomy in the past. Most women, I would say, are similar to this picture of uterine prolapse. So usually they have a little bit of all three things occurring at once. I do like to reassure people, this doesn't mean your bladder's falling out of your body or that your rectum's falling out of your body. What you're actually seeing there, if you are, suffering from prolapse, is your actual vagina. So the tissue that is bulging is vaginal tissue. It's just that those organs sit behind the vagina, and that's what's kind of creating the bulge there. So a good analogy is kind of like a hernia. People seem to be more familiar with abdominal hernias than they are with prolapse. So in an abdominal hernia, there's this tough tissue called the fascia that lies underneath your abdominal muscles. And when you have a defect or hole there, it allows a little bulge to come through. And what's poking out there is your intestines. So it doesn't mean that your intestines are coming out of your body. It's just you have a defect in the fascia there. And as a result, the intestines can kind of slip through. So even if you have super strong abdominal muscles, if that fascial defect is there, you can still get a bulge. So a similar thing kind of happens with the vagina. If you lose some support and a defect forms, it causes the organ line behind it to push into the vagina. So it just means you've lost some support of the vagina itself. This is why sometimes, even if you do have very strong pelvic muscles, and a lot of women will say, oh, I do Kegel exercises, you can still have prolapse despite those muscles being very strong. Symptoms of prolapse are typically pelvic pressure, seeing or feeling a bulge or something protrude from the vagina, difficulty urinating because the bladder is kind of coming down some. They find that maybe their stream is slower or that they're not completely emptying. Sometimes have difficulty having a bowel movement. As I mentioned, sometimes a feeling that the stool is stuck, or they actually see a bulge protruding outside of the vagina. Usually it's not painful, but they will often describe like pressure or discomfort, either due to the bulge or even sometimes from the bulge rubbing on their clothes. So another important point is that prolapse does not cause urinary incontinence or fecal incontinence. So you can have prolapse without incontinence, or you can have prolapse with incontinence. Incontinence is leakage of urine or stool that you can't control. So sometimes I see women who have both, but these are separate conditions that really require separate treatments. So often people will, kind of think, oh, well, if my bladder's put back where it's supposed to be or lifted back up, I won't leak urine anymore. But the leakage of urine is typically due to loss of urethral support, not due to the bladder itself coming down. So treating urinary leakage is an entirely separate topic that we can discuss in the future if people are interested. But incontinence will not specifically be addressed at today's presentation. So there are different stages of prolapse. So when you see a provider with symptoms of prolapse, we do some measurements of the pelvic floor. And what we're doing there is we are kind of grading prolapse. So when you come in for a new appointment, we do a speculum exam, similar to when you get a pap test, a cervical cancer screening test. And we ask you to push down as though you're having a bowel movement or trying to push a baby out. And so for prolapse, there's stage 0, which means perfect support. Everything is exactly where it's supposed to be. So that's really no prolapse, right? Stage 1 is when there's the compartment is coming down slightly, but that is usually asymptomatic and very mild. So it's so slight, we typically don't even recommend surgery or treatment for it. In general, the vagina is meant to move and be dynamic so that women can give birth and have sexual intercourse. So having some mobility of the pelvic organs is very normal. Stage 2 is when the prolapse is within a centimeter above the opening of the vagina or a centimeter past the opening. And 3 is when it's really just coming outside of the vagina more than a centimeter. And then finally, 4 is the most advanced that you can have, and that means complete eversion of the vagina. So kind of the whole vagina has turned inside out. And most women that we see are usually stages 2 and 3. So usually once the prolapse is at the opening of the vagina or slightly past it, that's when it starts to become bothersome to women, and they usually seek treatment for it. A lot of women ask, how did I get this, or what caused this? It's usually multifactorial. So most common cause is children. So often women who, the more children you have, the higher risk of delivery. And interestingly, even women who've had cesarean deliveries can get prolapse. So sometimes just the act of, carrying a baby can cause some stress on the ligaments and pelvic floor, even if you had a surgical delivery rather than a vaginal delivery. Other contributors are age. As we get older, our collagen levels decline and our muscles get weaker. So we see sometimes it becomes more prominent as we age. Genetics definitely plays a role. Things that cause constant strain or stress on the pelvic floor. So chronic constipation, so people are having to bear down and push a lot, are at risk. Morbidly obese people, so if they have a lot of pressure in their abdomen, that pressure is transmitted to the pelvic floor, and that puts them at higher risk for prolapse. Certain collagen disorders like Ehlers-Danlos syndrome can increase your risk. Muscle weakness, and then interestingly, there are some activities that can put you at risk. So there was a study on female paratroopers in the military that had a higher risk of pelvic floor incontinence and prolapse because of the opening of the parachute, causing so much impact when the chute opened. But most women aren't doing things exercise-wise that are going to put them at risk for prolapse. So a lot of people say, oh, should I not exercise if I have prolapse? And the answer is you should definitely continue to exercise. It's actually helping you continue to strengthen your core and your pelvic floor. And most of the things people are doing are not, putting them at risk for additional prolapse or worsening of their prolapse. So, what can you do to treat it? One option is to do nothing. If it's really not bothersome to you, it's not a life-threatening condition. So one option is to just, monitor it. You don't have to undergo any specific treatment for it if it's not bothersome. You can do pelvic floor physical therapy. So there are specialists who have trained in strengthening the pelvic floor that you can see that can sometimes help people become less symptomatic. There's something called a pessary, and then surgical treatment is the other option. And I'll go over each of these in more detail. Now, in terms of doing nothing, that, as I mentioned, it's an option if it doesn't bother you. The only time I've ever really said someone has to have surgery is when they had a stage 4 prolapse and it was blocking their their urethra and making it difficult for them to urinate. And so in that case, and unfortunately, like a pessary wouldn't stay in, so that was the only really option I had for treatment for those folks was surgical. So that's really the only time prolapse is a true emergency. If it's blocking the bladder or the bowel and keeping someone from defecating or urinating normal. Otherwise, it's not something that you urgently have to get treated. It can get worse as we age. Again, as I mentioned, unfortunately, collagen levels and muscles sometimes get weaker as we get older. But most women, it stays about the same. So a lot of times people are worried it's going to get acutely worse. But for most women, it stays pretty stable over time. So again, if it doesn't bother you, you do not need to do anything. I mentioned pelvic floor physical therapy. So some people haven't heard of pelvic floor physical therapists, but again, they are physical therapists who have done additional training, specifically in treatment of the pelvic floor. They usually see men and women. Physical therapy tends to help people who have like stage 2 prolapse. It's a little bit more challenging with stage 3 and 4 prolapse when it's actually protruding outside of the vagina. Physical therapy isn't likely to be as successful for more advanced prolapse. It also can work very well for urinary incontinence. But we do recommend you try it for at least 3 to 4 months before you decide whether it's helping you or not, because just like you can't go to the gym once and suddenly be super strong, you do have to consistently work at things for about 3 months before a muscle will start to remodel. So you really do need to try the physical therapy for 3 to 4 months before you are really going to see, a noticeable difference. Pelvic floor physical therapists are also trained to help with conditions like pelvic pain, pain with intercourse, pelvic floor spasm, and again, urinary and fecal incontinence. A general physical therapist is not the same as a pelvic floor physical therapist, but often pelvic floor physical therapists can do regular physical therapy as well, like traditional physical therapy. The next option is what's called a pessary. So pessaries, some of you may be familiar with diaphragms, which are was a contraceptive option, kind of that's gone out of vogue. But another equivalent is like a menstrual disc that a lot of women use now, or a menstrual cup. So they're kind of like that. They're these silicone, medical grade silicone devices that come in all different shapes and sizes, and they fit into the vagina to essentially support the top of the vagina and make the prolapse less symptomatic. It's usually not something you can just buy at a drugstore, because you are fitted for it based on your pelvic floor size and your particular prolapse issue. So it's something you do need to see a physician for. But they can be used long term. So they are something that you can be used for years. Ideally, patients should be able to insert and remove it themselves. They can be left in for several days in a row, or even for a few months in a row, for patients who really can't remove and clean it and put it back in themselves. Sometimes those patients will come see us every few months, and we'll do that for them. With the pessary out, your prolapse does come back. So it's not a fix, it just treats the symptoms, right? So when it's out, the prolapse, tends to recur. But when it's in, if it's fitting appropriately, you should know that it's there, and it shouldn't be uncomfortable. Insurance does typically cover them, and they're very easy to maintain. You just wash them with regular soap and water, let it air dry, and that's really it. If you are sexually active, we do recommend you remove the pessary, to have vaginal intercourse, but otherwise you can use them, for exercise, that sort of thing. And some women use them all day, every day. Some women only use them, if they're going to be physically active or go to the gym. It's really up to the patient how they choose to use it. So that's a nice non-surgical method that really most patients with prolapse can utilize. Again, just details on that. Different shapes and sizes. You're a urogynecologist. Some GYN doctors fit patients for that as well. And again, once it's in, you shouldn't even know that it's there. If it's falling down, that usually means it's too small. If it's causing a lot of pressure, discomfort, it's too large. So I tell people it has to be like Goldilocks. It's just right. So you don't even know that it's there when it's sitting in. It can be used in women of all ages, and again, use it as you see fit, but you do need to see your provider to get an appropriate fit to make sure that it's comfortable for you. And then lastly, there's surgery, right? And so some people prefer to choose try the more conservative options first, such as pessaries or physical therapy, before they opt for surgery. But it's not a mandate that you have to try those things in order to have surgery. So I do have some patients that are like, hey, this bothers me, I want definitive treatment for it, and they opt for surgery. There are a lot of different types of surgery you can do for prolapse. You can keep the uterus, or you can remove it. You can keep the ovaries if you want, or remove them. You can use a mesh to help support things, or you can use your own tissue and ligaments to support things. You can do surgery vaginally, laparoscopically, or even a combination of both. But the bottom line with surgery is the surgeon does a procedure that pulls things back up to where they are anatomically supposed to be. And we'll go into a few of the different types of surgery. Slides here. So in terms of surgical selection, it really is a conversation between the patient and the provider on how we ultimately determine what the best surgery for the patient is. It depends on the severity of the prolapse, what the patient's age is, what their activity and lifestyle is, whether they desire future vaginal intercourse or not, whether they want to keep their uterus or not, how much time they can take off work, what, the risks of the procedures, their pre-existing health. So, whether they're a good candidate for surgery. If they have a lot of medical comorbidities, we may recommend a shorter surgery than a more, complicated one. Long-term success rates. You always should have a conversation with your surgeon as well about their experience to make sure that what they're recommending is something that they do routinely and are familiar with. And again, choosing a mesh to support things, or your own ligaments to support things. This next slide is just a little algorithm that if patients are having a hard time deciding, and I won't go too much into this, but it's kind of a stepwise approach to help get to the point of, okay, what surgery do we really want? So the first one is, do you want to preserve, the vagina in order to be able to have intercourse? then do you want to keep your uterus? Yes or no? Do you want to do this all vaginally or laparoscopically? And then, we kind of go from there. So we go in over all these details with the patient prior to surgery, and that's kind of how we decide upon the best procedure for them. So if you have a cystocele, and let's say you had a cystocele only, there's something called an anterior repair, where you make an incision along the vaginal wall. You basically peel the skin of the vagina back. You identify the defect that is there. And with a few layers of sutures, you repair that defect and then you close the skin over it. So that's called an anterior repair only. Now, remember, most women don't just have one side that's coming down. So the vast majority of time when we're doing prolapse surgery, we're doing a combination of these things. We're not just doing one. And we definitely recommend doing everything at once because it wouldn't make sense to space them out. It's just longer recovery for you, more time under anesthesia, more expensive. So we definitely recommend addressing all three compartments at once, plus your incontinence, if you have that issue as well. If you have a defect on the backside of the vagina, as mentioned, that's called the rectocele. You can do what's called a posterior repair. I tell people it's similar to like if you were to get an episiotomy in childbirth, you basically make an incision along that posterior vaginal wall. So you cut the vaginal skin. Again, you peel it back and then identify the defect, and in layers, you repair that defect with sutures that dissolve on their own, and then you close the skin over it. Often we are also bringing muscles back together that are disrupted with a posterior repair. We call it a perineorrhaphy, but it's basically bringing the muscles at the opening of the vagina back together. And as a result, sometimes the opening of the vagina is slightly smaller if they have significant prolapse where that needs to be repaired. So that is a posterior repair. So your bottom is a little bit, sore after that procedure. Next, we'll talk a little bit about mesh surgery. So some people have pretty significant prolapse, or they say, you know what, I don't have, I want to reduce my risk of this recurring, because unfortunately with prolapse, sometimes it can recur. Now I do tell someone if they're 30, and we operate, this may not last you the rest of your life. I would, maybe it will, but you're very young, so this may not be a lifetime fix. Whereas if I'm operating on someone who's 70 or 80, there's a good chance their prolapse will never come back, right? It'll probably be a permanent solution for them. But one of the advantages of mesh is it can help reduce your risk of prolapse recurrence. Mesh has kind of gotten a bad rap over the years. So what's interesting is the mesh that we use, it's the exact same mesh that they use for hernia repairs in the abdomen. So it's been around for many, many years. It's polypropylene. It's a surgical fenestrated mesh that goes in to essentially offer support. Your tissue basically kind of grows into it. So it creates a scaffolding or platform to help support things. It's been around, like I said, for a very long time. For a while, there were these mesh kits that were inserted vaginally, and they hooked through the pelvic floor muscles. And so up to 30% of women were getting pelvic pain, pain with intercourse or mesh erosion with those, where the mesh would kind of hook into the vagina or even into adjacent organs. So that's where a lot of those lawsuits stem from that you may have seen. They're becoming less common now because those kits are off the market. So mesh was a little bit thicker and stiffer then, and they were using larger pieces of it, and those really are off the market. But we still use mesh today. We use it for urinary incontinence, and we use it for prolapse because it does work very well, particularly with people with more advanced prolapse. And although there can be, risk with putting an implant in, just as if someone got, a breast augmentation or other surgical implant, there's always risk of infection. But the risk with using mesh nowadays is more along the lines of 4% instead of the 30% that you may have seen when you Google mesh and see, these lawsuits or people talking about if you've had mesh, call 1-800-lawyer. Part of the challenge with mesh is because your tissue does grow into it. If you're in that rare percentage that is having, pain from it, it can be very challenging to remove. So you can often remove a good portion of it, but sometimes you can't get it all out entirely, because to put it in, you kind of sew it on, but to get it out, you literally kind of have to chisel it out, bit by bit if someone wants to have that removed. But to put it in perspective, I have never had a patient say, I want all of my mesh removed. I've had, a handful of patients, are probably more around the 1% outcome, that have had mesh erosion where it kind of pokes into the vagina. And part of the reason that occurs is because the vaginal tissue is very thin. So sometimes, particularly as we age, that gets thinner after menopause. And so the mesh is more likely to poke into the vagina. If that occurs, honestly, it's pretty easy to manage. You simply you do to go to the operating room for it, but you snip the mesh that is eroded, and then you close the skin over it. So it's usually not a significant issue if you do get a mesh erosion. I've only had one patient personally who wanted a sling removed for incontinence, so where I took out a complete sling. And then I have seen some patients who were referred to me who had mesh placed where honestly, it probably wasn't placed quite correctly in the first place. So they did have more significant issues, such as like mesh in the bladder. So you see it, but it's incredibly rare. Like I can tell you on one hand, the number of significant cases I've seen over, I won't say how many years I've been doing this, but it's a long time. So that's kind of mesh surgery. And so one of the primary procedures we do for prolapse with mesh surgery is what's called a sacrocolpopexy, excuse me. So I tell people it's kind of like suspenders for the vagina. You sew a strap of mesh on the front side and the back side of the vagina, and then you attach it to a very strong ligament that runs over the sacrum. It's called the anterior longitudinal ligament. And that essentially holds things up from above. And then we cover the mesh over with what's called the peritoneum in the abdomen so that none of it is exposed to the bowel or other organs. So you don't get erosion into the bowel or anything like that. This is done laparoscopically, and again, it's a nice option for women with more advanced prolapse, or particularly for younger women who are very physically active. It just helps reduce their risk of prolapse recurrence. So sacrocolpopexy is one option. Another option, I mentioned patients' desire to have vaginal intercourse in the future. Most people do not opt for this, but there is something called a colpectomy where, believe it or not, you can completely close the vagina. You usually are doing this for more significant prolapse, like pretty advanced stage 3 or stage 4. So the vagina is almost completely averted. And so I most commonly see women who opt for this are typically older. They may be in their like 80s. They aren't as concerned with having sexual encounters. They may have medical comorbidities that make having a longer surgery contraindicated, because this one is probably, I would say, the quickest and easiest recovery, because you're really just peeling the vaginal skin and then closing the muscular tube, right? So it's a less invasive procedure than some of the other ones. The other procedures, if we're fixing everything, meaning the top, the front, and the back of the vagina, plus or minus a treatment for incontinence, those are usually about 3-hour surgeries. So they're a little bit longer time under anesthesia. Most women have, no contraindications to that. So I operate on women, as young as their 30s, to their 80s. I think even a handful in their early 90s if they're pretty healthy. So most people are candidates for surgery. It is an elective procedure, so we, want to do it when people's health is kind of optimized. So meaning they're not actively sick or anything like that. But this, for folks who may want something less invasive or may have not quite as good health, this is a nice option for them. So that's closing the vagina completely. You can use your own tissues to support things. So one option is what's called a uterosacral suspension. So that's basically when you use the ligaments that typically support the uterus. Those are called the uterosacral ligaments, and you attach the top of the vagina to that. This can be done laparoscopically or vaginally. I shouldn't say I'm not a fan, but I don't do this procedure quite as much because I often find that these ligaments aren't always in the best condition and when with prolapse. So a lot of times their uterus is coming down, these ligaments aren't quite as strong, and so they have a higher risk of recurrence sometimes when you use these ligaments. So I tend to do these when people have less significant prolapse or they're getting surgery for another reason, like a hysterectomy, and we want to do just a little additional support. You basically use these ligaments and put some permanent sutures there to attach the vagina to it to help, prevent prolapse or treat mild prolapse. Another ligament in the pelvis is called the sacrospinous ligament, and this is a ligament that runs kind of over the gluteus muscles, and so you can go through the vagina and attach the top of the vagina with permanent sutures to this ligament. This is a great option. You can use it for more advanced prolapse. You can see though in these photos that it supports the top of the vagina, but doesn't necessarily correct the bulge on the front and the back of the vagina. So this is where you would also do like a cystocele and rectocele repair that I mentioned earlier. So separately closing or repairing the front and back of the vagina. Because you need to address all three compartments to make sure people have good support. So this is a good option to support the top, but again, usually you're doing some concurrent anterior and posterior repair to help give them the additional support that they need. But I do this quite often. A lot of women opt for this, over VASH. I'd say it's probably 50-50 what people decide. The other thing is there's not really any difference in recovery. The pain tends to be about the same. I'd say average, if you work outside of the home, probably 2 weeks off work is a reasonable time to take if you're getting all three compartments repaired. If you're just doing one compartment, it could be as little as a few days, off work. But I'd say if you're really doing something where you're addressing all three compartments, average is about 2 weeks off work. But most of this is done outpatient. So you go home the same day, you're out of the hospital by the evening. I'd say people are usually needing narcotics for 3, maybe 4 days at most. Once you are no longer requiring narcotics, you can drive. You're definitely not bedridden. In fact, we want you up and walking that day because staying in bed all day puts you at risk for, blood clot, infection. So getting up and being mobile after surgery is actually going to help you feel better and is encouraged. So there's no bed rest really after the surgery. The main restriction is nothing in the vagina for 6 weeks. So, tampons, hot tub swimming, intercourse, of course, because you want everything to heal and not get infected while it's healing. So nothing in the vagina for 6 weeks. And no vigorous or high impact activity for about, 4 to 5 weeks. And that means running, jumping, lifting, I'd say more than 30 pounds. Some of these restrictions are, there's no great science behind them. It's more theoretical. But you'll find that as you're recovering, most people don't want to go, run 10 miles around the block anyhow. So your body tends to limit itself and let you know what you can and can't do. But walking is, like I said, completely acceptable and in fact encouraged. A lot of people ask about stairs after surgery. They're totally fine. They're not going to disrupt your surgery. The only thing I tell people about going home and stairs is that, particularly the first 3 days or so when you're on narcotics, you should try to limit the number of times you're going up and down stairs because we don't want you getting dizzy and lightheaded and falling downstairs, right? So it's more of a safety issue than it is a concern about you disrupting your surgical repair. You're not going to do that by walking up and down stairs. I do kind of joke though, you can tell your family whatever you want. You can tell them I said no laundry, no cooking or any chores for 2 months if you'd like. Your secret is safe with me. So again, for surgical repair, usually we're doing some combination of these, and it really depends on the degree of prolapse you have, your personal preference, and the decision, like I said, is really made in partnership with your surgeon to arrive at the best option for you and your, particular condition and situation. And again, keep in mind, none of the procedures that I mentioned fixes incontinence. So that's a separate procedure that can be done at the time of prolapse surgery. And and in fact is recommended if you do have it. But we are looking to have a webinar in the future to specifically talk about the different types of incontinence and options for treatment for those. So lastly, just a plug to say I would love to see you if you are attending this webinar because of personal reasons, or if you are dealing with this condition yourself. I am located. The clinic is in Wilson Boulevard in Arlington, Virginia. It's a beautiful new clinic. If you're familiar with the Arlington area, it's in that big structure where the Capitals practice. So the Capitals ice rink is there. So if anyone plays hockey, and there's the ice rink's on the 7th floor and we're on the 2nd floor. There's ample parking, costs $1 to park there. And because that clinic just opened not even a year ago, opened in December 2024, there's not a long wait to get in. So you can usually get in really within a week or two. Some places that have been in existence for a while can be up to 3 months, before sometimes you can get in for an appointment. So would love to see you.